Hi guys, and welcome to Traumatic Injury. My name is Erin Putney, and I am a master's student at Wesleyan University here in Lincoln, Nebraska. And today I'm going to be talking to you about traumatic injury. A little background about me: I have been a nurse for about 10 years. During that 10 years, I've spent 8 of it in the hospital working as an oncology nurse up in the med center at the bone marrow transplant unit. I also worked, I transferred to their trauma unit in the ICU, and it's a level 1 trauma facility. So I did a lot of traumas there: gunshots, gangs, car wrecks, drugs, all, the traumas that go with bigger cities. And then I transferred down to Bryan West here in Lincoln and worked in their trauma ICU for about 4 years, and several, farm accidents and car wrecks and a lot of the same things that you get in bigger cities. This lecture is by far not inclusive because trauma takes years to get to know and used to, but it is a kind of a snapshot in trauma nursing. Welcome to my patio. I thought it was a gorgeous day out, so we're outside discussing this. So you might hear some car noises and birds and an occasional dog barking at a squirrel. But we're going to have a fun lecture, and I look forward to getting to know you guys. We're going to talk about primary survey, as this is the first and initial part of taking care of a trauma patient. Now, primary survey really depends on where you are in nursing. First of all, if you are the first responder to a scene, we aren't going to start with A. We're actually going to start with S, and S stands for safety. Okay, there's a lot of things that are out there in the world that are going to give us safety issues. If this trauma was in the water or in a boat or something like that, we're going to have different safety issues than if we're in the hospital or if we're in the ICU or something like that. So safety is definitely something that you learn in like your CPR course as a first responder, but let's not forget it when we're doing our primary survey when we're talking about safety, because it comes in all sorts of shapes and sizes. Now we can start getting into more of the medical stuff in our primary survey. Airway and cervical spine, or you'll hear me call it C-spine. Those are really important things to assess early, often, and to maintain. Our airway, if we do not have an adequate airway, it doesn't matter how good we're doing anything else. The patient's not breathing, and you have about 3 minutes before we start having complications from lack of breathing. C-spine's another one that, again, if we don't maintain C-spine, so we're not holding that cervical neck aligned, we're causing more damage than we're preventing. So those are the two things in the primary survey that have got to be first. Now, if you're in a hospital and the paramedics or the EMTs have already brought you this person, they're probably already in a collar. They may be already intubated. So those things then are already taken care of, and you can relax your mind. But you always have to pay attention, because airway can change very quickly, especially after a trauma due to swelling or any injury that might be in that area. Breathing is another spot that we're going to stop and check. Again, if you're out in the field, you're doing that look, listen, feel kind of thing, feeling for that breath on your face, and looking for that respiratory status, looking for that chest rise and fall. Those are things that are going to be very basic out in the field, whereas in the hospital, you might already have this person on a ventilator. But again, you're monitoring it consistently because you want to be watching, is that oxygen really getting around? With traumas, especially when you don't know exactly which kind of trauma you have, there's a lot of complications that go in there. Circulatory assessment, we're going to be feeling for that pulse, okay, and doing CPR if we don't have one. Now, the other circulation assessments, again, if you're in the hospital, you most likely already have a pulse, or you're hooked up to a bunch of monitors, and you know if you don't have a pulse very, very quickly. Disability is kind of an interesting one for D. What disability is actually your neuroassessment. Okay, and so you've got to be doing a good neuroassessment on your patient. Now, that gets complicated if your patient has come in from the field or gotten it from the ER or something like that, and they've given either pain medications or sedation. Your neuroassessment might be, or baseline neuroassessment might be, what you got in report, because that's what they were before they gave them a lot of their medications to do a lot of their procedures. So it can kind of depend on where you are. If you're out in the field and you're doing that, Annie, are you okay? That CPR check, that disability is you're assessing the brand new disability after the time of injury. So it really depends on where you are in the medical profession. But the thing is no matter where you are, you continuously do these types of surveys, because at any point in time, things can change. You can have someone who takes off your neck brace to look at an injury or something like that, and you have to maintain that C-spine even if that neck brace isn't on. Okay, so this primary survey, even though it's different from in the field versus in the ER versus in the ICU, it's really the same thing. We just continuously do it. So let's talk about the secondary survey. As we've gotten our primary survey, we're stabilized, we've got our airway and all that kind of stuff. Our secondary survey is we want to expose the patient, okay? And the reason we're doing this is because we're looking for other injuries, all right? We've already kind of checked what's going on with that head and that airway. We want to expose them now and see what we can find out, all right? The other thing, the next part of E is environment. And what we want to pay attention to in the environment is we don't want them to lose too much heat, okay? Their body heat is something that's really important for them to keep as they go through that traumatic experience. Being hypothermic can cause a lot of problems because they start to constrict and start to have other problems in their blood vessels and that kind of stuff. So we really want to make sure that we're not losing too much body heat as we strip away their clothing and to look for other injuries. F is full set of vital signs should be obtained. Now, again, this is very different if you are in the field. You're waiting for the paramedics to get there so that you can get that set of vitals, versus if you're in the ICU, I have, 10 sets of vitals before they ever get to me, but I'm going to get a full set as soon as they get into my ICU unit. Family. Now, family is a tough one because you have no idea what's going on with this trauma patient. You have no idea, is it the family member that shot them? I mean, there's just a lot of pieces of that puzzle that you just don't know what's going on. What I really recommend with family is having a nurse or a chaplain or somebody that is specifically with a family member so they can explain what's going on. Families do not understand what they see. It is our everyday, but it is not theirs, and it is their loved ones. So any logic that they had is gone. It's shut off. They are totally on adrenaline and emotion right now. And so they really need someone with them to be explaining what is going on to their loved one and what we're trying to do. Okay. G is giving comfort, and that can be in the form of pain medications to the patient, depending on the trauma. It could be giving them support and telling them what we're doing, like we're moving you from one bed to another. It really, really depends on what's going on with that trauma patient. You can have trauma patients that are completely awake and oriented, and you can have trauma patients that are sedated and paralyzed. So it really just depends on what kind of trauma patient you're going to get, but you really want to give comfort as much as possible. The next thing you're going to do is H, head to toe assessment. You want to get that head to toe assessment done, looking at everything, because they're going to whisk them out of there so quick that you do not have a ton of time to get stuff done, and you want to be very systematic as you can be. The history is nice if we can get that from the family member. So that's another reason why it's really nice to put a nurse with that family member. We can be asking about allergies, last time they ate, if they had any medical conditions that we should know about. If they use drugs and alcohol is always one we should probably know about pretty quick. One, because it lets us know how much propofol we necessarily need to give them. If they're an alcoholic, we're going to have to give more. If they're not, we might give less. It just really depends. But if we can get some of that history either from the family member as we're going through and working on a patient, this is very, very helpful. The last little part of this is the eye, and we're going to inspect the posterior surface. especially with car wrecks, we get glass everywhere, and so we really need to be looking on that back side of it to make sure that they're not having some sort of glass back there that they're laying on for a prolonged period of time. And it'll give you an idea of what's going on that backside, if there's any bruising showing up, because again, you have no idea what kind of trauma this patient has been through, so we really need to pay attention. The one thing that we have to be really careful of, and we make sure we do when we get to the secondary survey, is the bleeding. Okay, everybody gets thrown off by this. They want to look at bleeding like first thing. Like when you see a bad car wreck, the first thing you see is all the blood. That is not our primary survey. That's not our primary prevention. It doesn't matter if they're bleeding. We've got to get that airway, breathing, and circulation taken care of long before we worry about the bleeding. So the secondary survey is where we start looking at that bleeding. It's in the exposing time. When we expose them, that's when we're going to be looking for that laceration to the leg and all that kind of stuff. It doesn't matter if our patient isn't breathing. That bleeding's not going to matter much. We got to take care of the breathing issue first. Let's talk about some things that complicate our primary survey. So we're doing our primary survey. Remember that A is for airway. And we're looking at this guy. You can see that we're going to have some pretty significant airway issues because we have a pretty big facial injury. You could potentially see maybe a neck injury. There's not a lot of neck there for injury, but our facial injuries happen a lot of time. You can see this big swelling coming on his face. He's got blood coming out of his nose. So you know that there's stuff broken and not right in that facial area. Something we can do quickly if we're on the scene to maintain this airway is to get an oral airway in, and that will help us if we're bagging them or having to do mouth-to-mouth, although I wouldn't do mouth-to-mouth on this gentleman. So that's something that we have to think about. You can see the ET tube has been put in, and we've got probably some sort of gastric tube in there helping decompress the stomach. Airway is very complicated in these guys because they get so swollen so fast and stuff is squishy and out of alignment and not moving real well. And you can see how they had to tape this tube down here versus usually we tape it over the nose. But most likely there's some sort of break in there and we can't. Another one is that neck injury. If we have neck injuries, that can complicate our airway, and we might have to have to help put in a trach in a patient to help maintain that airway. That's not something that you or I are going to do. That's something that somebody with more training is going to have to put in to get that oxygen going and getting it, saving this person's life. When we're talking about other things that complicate our airway or at this point in time our breathing is the ribs. When our ribs hurt, we aren't going to breathe very well. Well, what happens when we get rib fractures? We hurt our ribs. Little hairline fractures that people get are not as horrible, at least in theory. They hurt really bad and people don't like to take deep breaths. Something that we have to pay attention to, though, is the tissue that's underlying where the ribs are broken, because in order to break ribs, you have to have some pretty significant impact. So if we're looking like right on this spot, if we're looking at what's under here, you've got the heart. I know, not drawn anatomically correct, but you've got the heart and you have all the blood vessels coming off of it. And once we have those blood vessels coming off of that, if we've had that impact there, a lot of that tissue could be bruised or have gotten sheared or pulled away from the walls that they're attached to. So we really have to pay attention to that. If we go down lower, you've got your spleen and your liver. And if either of those get what they call fractured or torn, they can cause a lot of bleeding and a lot of problems. So with rib fractures, they do not have to be broken all the way through. They can just be cracked, but in order to crack them, there has to take a significant amount of force, which means the tissue underneath that also took a pretty big impact. So you're more concerned about the tissue under it than necessarily the ribs that are broken. Ribs that are broken can lead to another problem, but a very significant one, what we call flail chest. Flail chest is when sections on both sides of the ribs get broken and they're kind of just floating in there. Once we get a flail chest, we're going to have some problems maintaining the pressure in our lungs, not to mention it hurts like a dickens, and these will have to be surgically fixed. They're going to have to go in and plate these or somehow adhere these to each other because of the problems that they'll cause. Other broken ribs, as long as they're not displaced, we really don't do much to treat. And I know people see in the movies ACE wrapping around people's chests when they have broken ribs, but really we don't do that anymore. It's better to just let the tissue and the bones heal versus putting more pressure on that tissue when it's already having enough problems. Sometimes it can feel better, so people might do it, but it's really not medically necessary. As far as flail chest, though, this is going to need some sort of medical treatment to go in here and fix these ribs and get them reattached. Things that I see that cause flail chest, because you have to think the impact is pretty huge. The things that I see that cause this is I've seen a bull ram someone in the middle of the chest, and his flail chest was more over his sternum. So those are kinds of things, but it's going to be a pretty big impact and pretty focused impact in that area. Breathing with the flail chest has an interesting look to it because where that area is flailed either sinks in or it pushes out. So when we have you look at people's chests and we ask them if they're breathing symmetrically or not in your assessment, this is why one of the reasons we're looking for that, because we're looking for areas of asymmetry. Something isn't right. So this person, when they breathe in, you suck in, and so then the chest collapses in a little bit, and when they breathe out, you push out. So then that little area bulges out. Causes a lot of pain. It's called paradoxical movement, and it causes a lot of pain. Stuff we have to get fixed for them. Something that can happen when we have a significant chest injury is called a pneumothorax. And what this means is that air is filling around that pericardial sac. So on image A here, you see that not only do we have air filling the sac, we also have air coming in from the outside because maybe the lung punctured that area and it's open to air. And we also have the trauma on the inside of the chest, which is allowing air out of the lung itself. The lung tissue is very, very sensitive and very thin, so it gets damaged pretty easily, and we have to be really careful about that. As air fills this area, it's going to make this lung get smaller and smaller and smaller. And if you have a completely collapsed lung, they're going to just have no lung tissue there. Okay. On image B here, you can see that while this one still has a very small lung, there's no external air coming in because the pleural sac was not broken. All right. So what they're going to do is every time they breathe in, that air comes out and fills that. And if you think of it like a balloon just getting fuller and fuller and fuller, and it's just squeezing that tissue smaller and smaller and smaller. A tension pneumothorax is what we get when we do not fix the pneumothorax, right? So the pneumothorax, that tissue, that lung tissue has gotten smaller and smaller and smaller. And if you think of like a balloon inflating in your chest because it doesn't allow the air out, it's going to start pushing on stuff, and it's going to start pushing it against the heart. And once we start pushing against the heart, what kind of symptoms do you think we're going to see? We're going to see blood pressure drop. We're going to see heart rate increase because it's trying to beat faster. We're going to see our patient getting sweaty because they aren't able to perfuse as well. They might get pale, and eventually they might go unconscious. And I can't spell, and I'm just going to apologize for that, but that's unconscious-ish. All right, so they're slowly going to lose that. This becomes a medical emergency. All right, how you're going to know that they're having a tension pneumo is one, all of these symptoms, and two, you're going to look at them and that trachea is going to deviate to the side. Okay, so you're going to look at them, you're going to be like, huh, something looks really weird in their throat. They're not really responding to me. Something's not right. They don't look right. They can't get their breath. Their respiratory rate might go up because they're just trying to breathe just a little bit faster to try and get it. And that pressure just keeps building against that heart with every breath they take in. Okay, this becomes a medical emergency. We need to treat this, and we treat it by putting a needle in here to decompress that air. So what's called a thoracostomy is what we're talking about. You're going to find the biggest, baddest needle that you've got. This is not a little 24 gauge. If we can go 16 gauge, that is a great needle for this kind of thing. Again, this is something where you're going to assess your patient, and you're probably going to call someone and say, hey, I think I need help. My patient doesn't seem to be very awake or is not really responding, and there's some changes. The breathing's not right. Something's wrong. So we're going to talk about needing to get some help. This one, you're going to see the trachea start deviating to this way, because the trachea is going to deviate away from the air because that sac is filling up and pushing against that heart. So you're going to want to put that needle in between and poke and get air out. I will be honest, in my 8 years of working in critical care types of environments, I have seen this done once, and it was done by the surgeon and not a nurse. So it's pretty rare. It's not something that happens all the time, but it can. Something that can cause it actually is a chest tube that's in place, and we'll talk about chest tubes here in a minute. Chest tube in place where it gets kinked off. And so no one's paying attention. It gets kinked off in a bed rail, and then all of a sudden they're not breathing real well because that chest is starting to inflate with air instead of the air coming out in the chest tube like it should. So something to pay attention for. Again, if you're assessing your patient and you notice some changes, the nice thing about in the ICU or the ER or in any trauma is you have a team of people to help you. So use your team appropriately and ask for help. We've talked about pneumothoraxes, which is air filling that pleural sac. A hemothorax is blood filling that pleural sac. And you can have other types, pus and just other fluids filling it, and they all have their different names. But for the most part, those are the two things: is the pneumothorax and the hemothorax. They're your biggest ones. One's air, one's blood. What's kind of cool is it changes where you put your chest tube. So like in a hemothorax, we're going to put our chest tube down low because we want to be able to get all that fluid out. If you put it up high, you're not going to be able to get all that fluid out because all the fluid's going to be below it. Use gravity as your friend. Now, when we have a pneumothorax, we want that chest tube up high because we want to get all the air out. So that helps you sometimes when you walk in a patient's room determine what kind of chest injury they have, because depending on where that chest tube is depends on what we're trying to get out. A hemothorax is just blood filling that space, again compressing that lung, causing problems, and we've got to get that fluid out so that we can get the lung re-expanded so that they can breathe well and efficiently. So let's talk about chest tubes, because we've kind of dabbled on that a little bit in some earlier slides. There are many, many styles of chest tubes, and you have to just get used to whatever style that your facility uses. This is an atrium. All chest tubes are pretty much the same style, same things that they do, just a little different quirks here and there depending on the maker. So like this one, you can see here's your water seal is where the A is. Where your B is showing your suction. Usually there's a little like dial or something in there to show you like what your suction is set at. C down here is the bubble chamber. This is for your air leak, to show you if you have an air leak of some kind. And it'll give you different grades depending on where the bubbles are going to. This area here, this section D, that's where it's filling. So you can tell that this patient has a hemothorax because they have blood coming out. If you have a pneumothorax, you really won't have a lot of fluid in that chamber because you're pulling out air, you're not pulling out fluid. So it really can give you kind of an idea of what's going on with your patient here. Things to pay attention to is here's where your suction is hooked up so that it's hooked up to the wall. You can see here is where we're connected to the patient and we're going up to our patient. Paying attention to our chest tubes, we need to make sure that you can kind of see that there's this white plastic under here. That's a kickstand. You need that kickstand out, okay? If this chest tube should get tipped over, you have to change out the whole thing, because as you can see with this patient, they're probably at about 1,400 mLs that they've lost fluid out. Now, is that 1,400 in 12-hour shift? Is that 1,400 since they've put it in? We need to make sure that we're marking and documenting how much fluid is coming out and the time frame that it is. But if this gets tipped over, it messes the whole system up and you have to change out the whole system. So making sure that little kickstand is out is very, very helpful, because look at this. This is the leg of the bedside table. Not to mention, think about the IV poles that we have in there, the ventilators. I mean, there's just so many things that we have to pay attention to in that room. So we don't need to be complicating our day even more by knocking that over. So just keep the little kickstand out, or sometimes people tape them to the floor. It just really depends on what's going on, because you also have families in there that are causing all sorts of ruckus and moving stuff around. Chest tubes should always be lower than the chest, just like a Foley should always be lower than a bladder. Chest tubes should always be lower than the chest. So when you're transporting them to CT and stuff like that, make sure that your chest tube is hanging on the side and not laying in the bed and that kind of stuff. Nursing responsibilities when it comes to chest tubes, we are to assess, and not just assess the chest tube, but assess the site, and, silly thing, assess your patient. Are they breathing well? When you listen to their lungs, do you hear your lung sounds in all lobes? Is there something going on that you're not hearing or seeing? Those are things that we need to assess for, okay? Bubbling is okay. So when I talk about bubbling, you might see a couple bubbles in here. Bubbling here is fine because that's where our suction is hooked to, and this bubbling is the water chamber and how we keep from bacteria and air going back into our patient and going up these tubes and all that kind of stuff back to our patient, all right? So that water chamber is really important to keep it going. Titling is even better. If we see titling, it'll correlate with the patient's breathing. So as the patient's breathing, you'll see the water go up or down, and if they as they breathe. So it kind of correlates with it, and that means that that lung is re-expanded. So titling is a good thing. We want to maintain suction. So we talked about here's your suction hooked to it. If this gets kinked, then nothing's being sucked out, the air's not being sucked out, the fluid's not being sucked out, so that means that the chest tube's not doing its job. So we want to always make sure our suction is working. The water level we talked about here, we want to make sure that water level is where it needs to be, because it's protecting our patient and not going back into not letting bacteria and air back into our patient so that it can go back all the way up the tubes. All right, so we want to maintain that water level. If we have too much bubbling in that section, then that means that the water is just going to dry out faster from evaporation and stuff. So you might want to turn down your suction just a little bit, because your suction is maintained through this little piece right here of whatever it's set at. And then documentation. We want to documentate our site, the fluid that's coming out, or if there's any coming out, okay? Maybe we don't want fluid coming out because it's a pneumothorax. We want to document their respiratory status and what's going on there. And then any bubbling or air leaks that might be happening, because sometimes you'll see bubbling in this chamber C here, and that means that there's a little bit of air leak. It's common to have air leaks with chest tubes just because it's hard to seal things in a human body. So a little bubbling's okay. If we're getting a lot of bubbling, we're probably not very sealed, and we need to look for where that leak is. And remember, when you're working in the unit and you're getting a lot of chest tubes, you will be trained on these better. This is just a quick snippet of chest tubes, so when you see them, you understand what you're looking at. Let's talk about shock. So when it comes to shock, it is a result of an injury or something going on to the body. Usually we notice it because we have an increased heart rate as the body tries to compensate for the decreased blood pressure. All right, and sometimes and frequently we'll start seeing a loss of consciousness or a change in consciousness as people go into shock. The body is not meant for acute, sudden changes. It does fine with slow, steady changes because it has time to compensate. But it's not the fall that actually kills us. It's the sudden stop of meeting the ground. It's that sudden change that our body just can't adjust to. Hemorrhagic shock is the most common shock in trauma patients. Go figure. They bleed out. They have problems. Either you get in a car wreck and you're internally bleeding, or you get shot by a gun and you're externally bleeding. But it is the most common one for trauma. The worse it is depends on how much blood you've lost. The more blood you lose, the worse it's going to be. All right. And we then need to replace it faster depending on what's going on. Neurogenic shock happens when we have trauma to our spinal cord. And when we have trauma to our spinal cord, it messes up the autonomic pathways. So all of a sudden, the brain and the spinal cord are not talking to the heart and the lungs and all that stuff to maintain our blood pressure. And then septic shock, the infection is causing such injury to the body that the body doesn't know how to do it. And again, you have the third spacing of the fluid, so the fluid goes out of your vascular system, which decreases your blood pressure, which makes your heart rate increase. So it's the same things happening no matter what type of shock you have, but hemorrhagic shock is the most common one for trauma patients. So what are our management strategies for people that are in shock? Well, for hemorrhagic shock, we have to replace what they've lost. So what we want is we want 2 large bore IVs. These are not 24s or 22s. We want 18s, 16s or bigger. If I can get a central line in someone, that's even better because I am going to be rapidly infusing fluids to get their blood pressure back up. Because if we don't have good blood pressure, guys, we don't have perfusion to the brain, we don't have perfusion to the kidneys, and we don't have perfusion to the lungs or the heart. Okay, so that perfusion piece gets so important as they start to go into shock and they start to lose a lot of volume. We can do LR if we need to. We can do normal saline if we need to. Sometimes you'll see half normal saline, just depending on what's going on. The other thing that we will infuse if it's a hemorrhagic shock is we're going to infuse blood. Packed red blood cells. Now, this little apparatus thing is called a level 1. It's probably one of my favorite toys in the ICU. It takes 2 nurses to use it, and what's nice about it is you can put 1 bag of fluid in one spot, you run it through the system. Now, what's nice is it warms the blood or the whatever fluid we're giving, because hypothermia causes problems. So we don't want to put people into hypothermia if they're losing blood. We want to keep them warm. Then you can put another bag in here, and it's a nice Y site and it connects in, and then you get 1 bag going. As soon as that one's done, you get the next one going. Okay, and this is why it takes 2 nurses, because depending on how big my access is, I can put in a unit of blood in about 5 minutes or less, depending on my patient and how fast I need to get this fluid going in. But that's going to take you a couple nurses to run. Pretty cool toy, and it works very efficiently. Traumatic brain injuries are one of the things that that traumas bring us. Okay, 1.4 million traumatic brain injuries occur each year. Men more often than women, because men with their higher testosterone like to take a few more risks than women usually do. But that's not saying much, because I've had plenty of women in my trauma units. TBI is probably one of the most disabling types of injury. Okay, we think about that we can heal everything, but honestly, we can't heal the brain. We don't really have any magic cures for healing the brain. I tell my kids all the time, I can fix any broken bone in your body, but I cannot fix your brain. Your brain has to fix itself. So all we can do for traumatic brain injuries really is time and supportive care, decreased swelling. Those are kind of and decreased stimuli. Those are kind of our priorities when it comes to traumatic brain injury. because we can't fix it. There's no Band-Aid that we can put on a traumatic brain injury. So when you're thinking about not wearing your helmet for your bicycle ride, just remember, everything about who you are is in your brain. I know we like to think about the heart, and our heart is so emotional, but really who we are is in our brain, and we can't fix that if it gets broken. Leading causes of traumatic brain injury. Falls is the biggest one that we have. Think about people that fall. I mean, you're talking about people that fall off of ladders, people that fall out of trees, people that fall putting their Christmas lights up, whatever. We have lots of falls. The other falls that we have are in the elderly population. We have lots of falls in the elderly. And to complicate things, think about what medications elderly are frequently on. Coumadin, Plavix, Xarelto, all anticoagulants. And when we have a fall, even a ground level fall in the elderly who are on these medications, it becomes a very big deal because we can't stop bleeding in the brain very well. It's not like we can put pressure on it. So this becomes, as we get an elderly population who frequently fall and are on these medications, it increases a lot of our issues with that population and with the falls. All right. Other reasons we have traumatic brain injuries are motor vehicle accidents. These are pretty common, unfortunately. The nice thing is we have seat belts now, which keep people in the car, so we don't see as dramatic of injuries with these patients as we used to, but it's still a high number. And then all forms of blunt trauma. This could be struck by or against something, as in assaults. Okay, we still see a lot of assaults where people get beat in the head. There's a reason why kids, they don't want you to throw the bat. They want you to kind of put that bat down and run to your base, because if you're throwing that bat, it increases the risk of head trauma for somebody getting hit by it. Anytime we get struck by something or we get hit against something, we're going to be at risk for that traumatic brain injury. Concussions are also a form of traumatic brain injury. They're a littler one for the most part, but they can be stacked on top of each other, causing increased problems with these patients who get a stacking effect from traumatic brain injuries. The nice thing is there's a ton of education now going on for people, coaches and stuff, for kids that are at risk of concussions. The 3 highest sports for concussions: football, hockey, and lacrosse. And so we see a lot of concussions from those, but I know plenty of people that get it from basketball, diving, I mean, just random things that cause concussions, and you just get hit in the head or any of that. So paying attention to those kinds of things is really, really important as we work and learn about patients with traumatic brain injuries. When it comes to traumatic brain injuries, there's different types of injury to the brain. Diffuse axonal injury, or a DAI, is the most common type of injury to the brain, and it's usually caused by what we call a coop-counter-coop brain injury. And if you know anything about physics, nothing stops until it either hits something or is slowed down, correct? So when we have someone going their head this way, right, they, like in a car accident, they bring their head forward, the brain is still going until it actually hits the front of the skull. Well, then there's a reaction. So as the head goes back, the brain then also goes back and hits the backside of the brain, or backside of the skull, sorry. And so when it does that, then we have damage, not only like bruising and contusion, but we also have this shearing effect that happens. And when we have shearing, you can see down here, when we have shearing, the axons start to have problems. Now, why this is so damaging and detrimental is because it's not a with a stroke, it's in one spot, right? We can go in, we can see where that stroke is, we can deal with the injury in that one special area. When it comes to these are like little pinpoints of injury throughout the brain, because they're all these axons that have just been sheared and torn apart. And then they release chemicals, neurotoxin chemicals, that then cause more swelling, which then cause more damage to the rest of the brain. So this is the injury where we have people that just don't wake up. They're in what we call a vegetative state. Okay, this is the type of injury that they have because they don't have one injury in one spot that we can go fix. These are also the patients that when they get really bad, all this tissue in their brain starts to swell. And when we start to have swelling in the brain, unlike when you have swelling in your arm from a sprained wrist, when you have swelling from your arm and as a sprained wrist, it can keep swelling. There's nothing holding it in. Our brain has an amazing protective bone called the skull. And once it starts swelling there, then we have problems because it cannot keep swelling and not go anywhere. You have the magnum foramen, which is where your spinal cord goes, and once we run into too much swelling, that is where your brain is going to go. Eventually your brain will do what we call herniate, and it'll pop out the bottom of your skull into your spinal canal. And once that happens, unfortunately, this person becomes a vegetable or they become an organ donor. So really good for the family that needs an organ, really sad for the family that wanted to keep their loved one. So on top of the diffuse axonal injury, which is the most common, there are also hematomas that can happen. You have the epidural hematoma, which is unfortunately what we call the walking dead. Okay, the reason we call them the walking dead isn't because they turn into zombies. It's because an epidural hematoma is an arterial bleed. Can't spell, is an arterial bleed. And so these are the people that they go skiing and they run into the post or the pole or a tree, and then they get up and they're fine, and oh, maybe they lost a little bit of consciousness, but they're fine now, no big deal. And then they decline. They have a quick change, loss of consciousness, and it's a quick change. And if we can get them to the hospital, we might be able to save them. But most of the time, these guys deteriorate so quickly that they can be very, very hard to stabilize and to keep. The other is a subdural hematoma, okay, which can be also from that from the countercoup injury. It is a venous bleed, so it's slower. Okay, and we can usually save people pretty easily from epidural or from subdural bleeds. Sorry, subdural bleeds we can save people usually because it's venous. It develops within 24 to 48 hours of injury. They might have some issues with loss of consciousness and all that kind of stuff, but we can go in there and we can do what we call drill burr holes, which is just a little hole. If you've ever seen like a hand screwdriver, that's literally what it looks like. We can drill a hole in there and we can take out that blood as it's clotted and everything like that. It's still dangerous and it's still deadly if not caught in time, but it's not as rapid as the epidural bleeds, so we have a little more time. The intracerebral hematoma is inside the brain tissue, and I don't see a ton of these. I see these more with cancer and with tumors, but it is a hematoma. It's inside the brain. We usually can't do much to go in there and get it because it's surrounded by brain tissue, so we let the body reabsorb it, and we just treat these guys by supportive care. And so we're going to just let the body try and reabsorb this as much as possible. If we have to go in and get it, if we can, we will. But typically, it's not going to benefit them from us going and digging around in their brain. These other bleeds are pretty much on the top and on the surface, so we can go in and kind of get those out without doing too much damage in the brain itself. So how do we help people that have traumatic brain injuries? Well, it really depends on where you are on the spectrum of working with these patients. The biggest thing that we're going to do, though, is our neurological assessment. And depending on where you are when you're getting this patient, if you're at if you're a first responder, your baseline might be just right after injury, versus if you're an ICU nurse, well, you've now gone through ER nurses and everything, they might be intubated and sedated. So it depends. Your baseline might be more about what they were when they came in and getting that from report. Now, it's really important that we have an ongoing neurologic assessment for our traumatic brain injuries because we want to know how they're doing. If they're sedated, it just makes that task a little bit harder. One thing that we do and the paramedics and EMTs do really well is they get a Glasgow Coma scale. And this gives us an idea if they measure the eye opening, the verbal response, and motor. If they're able to spontaneously open their eyes and are oriented to what's going on and have a motor and can obey commands with their motor response, they get a 15. Great score. We love those scores, okay? But when they start declining, they might have some confusion, all of a sudden not knowing where they are. They only may withdraw from pain and not really any other response. So those are things that show that we're declining. And those are things that we have to do and we want to do continuously throughout our shift and monitoring them. Pupils are another way that we can assess what's going on with our patient. The problem is pupils are a very late sign. So if you're going off pupils like they do in the TV shows, you're missing so many other issues that we're having. If you see a blown pupil, which means usually it's dilated to 4 to 6 or more, it's usually covering all the color in the eye, then we're seeing that that's some significant brain trauma going on in there. And we're probably potentially too late from what's going on, and we could have caught stuff earlier, hopefully. The other things that I like to pay attention to as an ICU nurse, because most of my traumatic brain injury patients are sedated, is I pay attention to the gag, cough, and breathing over the vent. Because think about if they're on a ventilator, I'm going to be suctioning them, I'm going to be doing oral cares, and I'm going to be monitoring their ventilation status. And those are all things that I'm going to monitor on the vent. So if they gag when I go to do oral cares or when I do a suction and they cough, then I know they still have some nerves intact that give me hope for them waking up. But if they don't have those 3 assessments, then I'm getting really concerned. Either I have them over sedated or paralyzed, which sometimes we do paralyzed patients, or there's a lot of nerve damage in there and we may not have much of a person coming back. Monitoring pressures is part of nursing, and we do it on every unit that we work. However, when we have a traumatic brain injury patient, we want to measure the pressure within the brain itself. So we have a cerebral perfusion pressure, or the CPP, that is the amount of pressure it takes to get the blood flow up into the brain so that we are perfusing and oxygenating the brain. Because here's the honest truth. If we do not have a good CPP, if we do not have good pressure in the brain, we are not oxygenating them, and then there's really no point in doing most of the things that we're doing. Okay, with the brain, we know it's swollen because it has a traumatic injury. We know it's swollen, so it's going to take more pressure to get that blood up into the brain. So we frequently run these patients hypertensive. So you might titrate your pressor, your vasopressin or your Levophed or whatever vasopressin drip that you're using. We might run that higher based on what we want. Normal is 50 to 60. However, a lot of times we want these patients to be 65 or right around that area. So you might get a doctor's order to titrate drip according to CPP of this, and it's whatever the doctor orders or the doctor wants. The intracranial pressure monitor, you see there's several different kinds that they use, is monitoring our normal or the inside of our brain, the pressure in there. Now, again, we know this brain is swollen. So while normal is 5 to 15, we usually are okay with anything 20 or less. We want to know what that ICP is. Again, because we know that brain is swollen, we know there's going to be a little bit more pressure in there. But we want to keep that pressure less than 20 because when we sneeze, that pressure goes up and then comes right back down. But with these patients, because the swelling is continuous or at least there for at least 3 days, depending on our treatment, we know it's going to be a little bit higher. So anything less than 20 is okay by the ICU staff. Cranial nerves are assessed often as we go through. Remember, we talked about that pupillary response, and it is the optic and oculomotor nerve. Again, if a patient is on sedation or pain medication or any of that kind of stuff, that pupillary response can be slow or non-existent depending on what's going on. And pupil responses are late stage signs of changes, so they're not really our first go-to. The corneal reflex is one where you touch the eye and it blinks. Again, if we have a patient on sedation, or even if we have them on a paralytic, which is common for patients with traumatic brain injuries, especially severe ones, you are not going to have any of these nerve reflexes because we've paralyzed them. So that kind of depends on what's going on with your patient. The hearing and tinnitus or dizziness is the acoustic nerve. This is going to be for somebody who's awake, so maybe you're more your concussive patient. We're going to ask them if they're having any dizziness or vertigo or tinnitus and that kind of stuff. But you're not really going to ask your patient who's intubated and sedated if they have any of that kind of stuff going on. The one that I use probably the most frequently, especially for patients in the ICU, is the cough-gag reflex, and that's your glossopharyngeal and vagus. These are the nerves that I'm going to assess every time I suction and do oral care. Okay, so these are the ones that we do frequently because when they're sedated, they aren't going to have a bunch of these other ones. They could still have some of the corneal reflex and the cough, but the pupillary, if we're given fentanyl, those pupils are teeny tiny. Like they're just not, and they're not going to move that much. So that's not going to tell us a whole lot. But our corneal reflexes will still be there, and our cough and our gag. Doll's eyes are a symptom of pretty aggressive and severe brain injury. If the doll's eyes are present, they move in relation to the head. So when the doctor moves their head, and hopefully doesn't do this with a spinal cord injury, but moves their head, the eyes move with it. Otherwise, if they're absent, the eyes do not move in relation to the head. The eyes move to where they want to move, maybe to stare at the doctor or whatever. But they're called doll's eyes because if you ever were a kid and played with some of those creepy dolls that their eyes moved, this is usually how they moved, is because they stayed in one spot. Again, doll's eyes is a pretty ominous sign of a pretty advanced or aggressive injury to the head. Posturing is another really bad sign that we have some really extensive injury to the patient. There's two different kinds. This is decorticate. So if you draw a line down the middle and the patient's arms, see how they're going to the core? That's decorticate, and the legs are kind of turned inward going to the core. This is decorticate. I can't spell. Anyways, decorticate, and it goes to the core. All right. The other kind of posturing, again, draw that midline down, is decerebate. And it's everything kind of goes away. You can kind of see there's more of a gap here between the knees. This is decerebate posturing. Okay, and this is, it goes away from the core. All right, and those are, again, both posturings are bad. Some people say one is worse than the other, but really both are bad. And if someone is posturing, it means that we have a pretty extensive head injury going on, and those nerves are so irritated that we're having posturing types of events. All right, for treatment of TBIs, remember, there is no Band-Aid and there is no clear fix to a TBI. The best we can do is to support them and let the brain heal itself. We've got some little tricks that we can help. One of those little tricks is to decrease stimuli. Now, some ways of decreasing stimuli are literally taking the family outside and telling them to keep their drama away from this patient. No petting of the patient, because if they pet them, they're constantly stimulating those nerves on their skin that then try and talk to their brain. So anything we can do to decrease stimuli helps. Some of the medical stuff we can do for it is to give them sedation. Propofol is one we give, Versed is one we give, and fentanyl we might give for sedation and for pain management. So those are all things that we can give to sedate them, to help their body relax so that brain isn't constantly going. If their brain is still going and we can't get them to chill out, we can give them a paralytic. And so literally we can paralyze all that nervous system so they can't move. That comes with its own set of complications, because if they can't move at all, you have no gag, you have no cough, you have no nothing, you don't know how awake they are, you don't know what their brain's gonna be like, nothing. So that one comes with its own set of complications. Some of the simple things we can do, though, is maintain alignment. When it comes to patients who are in this state with a traumatic brain injury, anytime we bend this neck, we cause a kink in the flow of cerebral spinal fluid and of blood. So if we can keep that neck and everything aligned, even down to like their hips, we will really help that patient decrease the stimuli and the extra pressure and everything that we have in that brain. So that's something really important that we want to pay attention to when we're working with these patients, is that maintain alignment. Another thing we can do is we can control swelling as much as possible. You cannot take all the swelling out of your sprained wrist. You cannot take all your swelling out of your brain. Things that we can do, though, to help keep that swelling down is just like with your sprained wrist, we can use cooling. We can't use ice so much because you can't get ice on the brain, okay? There's no way we can get ice into that brain, but we can do something called intercool. And that's something that people are using now to help cool down the body. And we'll talk about that here in another slide or two. We'll use intercool to help cool down the body and be able to bring down that temperature to decrease that swelling. The other two things that are here are your osmotic diuretic and your hypertonic solution. What both of these are doing is dehydrating the patient. If you remember anything about your fluid and electrolyte lecture, and when we talk about water and hypotonic solutions and hypertonic solutions, we give a hypertonic solution so that it pulls fluid out of the cell to dehydrate the cell so that it doesn't swell as much. And then we give the mannitol to try and get that fluid out. So sometimes they'll be given together and sometimes they'll be given separately. It just really depends on what the doctor orders. The other thing that we really want to make sure we're doing is maintaining perfusion for oxygenation. If we do not oxygenate the brain, there is no point in saving the person, okay? Because they won't have any quality of life if we can't keep that brain alive. So some pressors you might see are Levophed, vasopressin, epinephrine. Those are all pressors that we use on a pretty regular basis to try and keep blood pressures up. And remember, we might run them hypertensive to increase their CPP to get that cerebral perfusion pressure going. If your ICP keeps climbing and you're worried about your patient having an issue, because what happens with the ICP when it climbs, that means we're having too much pressure in the brain. That can happen if we're getting ready to herniate, not something we really want, unless we want them to be an organ donor, then herniation is fine. But typically, that's not something we really want. Hyperventilation is something we can use. It's something that we're going to have the respiratory therapists, remember we have them on our team, so let's use them. We're going to have them come in and do a hyperventilation, and that's going to be with a doctor's order. We're not just going to make that choice to do it on our own. It can be used to reduce the ICP in neurologic emergencies, like say we need to get that going while we get the Nimbex and all that stuff going, so we might need to hyperventilate them for a while. Purpose is to reduce the CO2 to cause vasoconstriction. It's used to prevent herniation. It's not recommended for routine management ICPs. This is going to be for an emergent, like, oh crud, we can't get their ICPs down. I think something bad's going to happen. We need to just get them so we can get all these medications on board. Kind of thing. It's not something that we're going to do often, and it's not a management, but more a treatment for just an acute episode of increased ICP. CSF drainage, or cerebral spinal fluid drainage, has negligible effects on the cerebral blood flow. So it's not something we're going to use to manage blood flow, but if we need to drain from their ventricles for a while, we can. What we do is we literally put a drain in here, and then we hook it up to a bag outside the body, and then we're constantly monitoring how much comes out. Usually all you want to come out is about 5 to 10 mLs an hour. Usually lower is better. We like the 5, but it depends on what your doctor's order is. Nursing responsibilities for this: you're going to level the transducer and the stopcock. You level it to the tragus of the ear. And again, if this is something that you're going to do in your unit, ask someone for help the first time you do it, because it's not something I see commonly as much anymore as I used to see. I used to see this a little bit more frequently at the med center, but not so much here. We'll take hourly assessments of ICP, so getting that intracranial pressure, and then drain the CSF as prescribed. Change collection bags only as needed. You really don't change a lot in that collection bag. So this is not something I see very commonly done for traumatic brain injuries. I think the only other time I saw it done was had a guy who had an aneurysm because he smoked crack, which if you have blood vessel issues, can cause that. And then we had to do draining on his brain to try and maintain, but he was not real compliant and not very sedated, so it didn't really work real great on him. But it's something that you might see in your nursing career if you do ICU in the trauma unit. Therapeutic hypothermia is within the first 72 hours, and it's for the first 72 hours. Think about when you sprain your wrist and you put ice on it. You really heavily put ice on it for the first 72 hours. After that, it's sort of PRN or hit or miss whether you get it on there. The reason we do it is for that same reason. It's to decrease the swelling. If we decrease the swelling, we decrease the ICP. Now, you can see here, this is the machine we use, and we usually like to get people down to 33 degrees Celsius, which actually equals about 91.5 degrees Fahrenheit. Okay, so that's pretty chill compared to what we normally are sitting at our 98.6 or that kind of stuff. Now, this is the catheter that we're going to use to put to cool people, and you can see this is the tubing that is actually inside their body, and it's up into the superior vena cava area, because what it's trying to do is it has like ridges on it that cools the body. So in these little areas is cool water ice or cooled water going in, and it's a closed system, so the water never touches the patient, just the coolness that gets in this tubing, and that's what allows them to cool. Here's the issue. If you get someone down to 91 degrees, we're going to have an issue with shivering, okay? Because their body's not meant to get that cold. If we do shivering, one, that burns a ton of calories that they need for healing, but the other piece is that it increases their ICP. This is where the paralytic comes on board. We give them a paralytic so they can't shiver, all right? So that their nerves and everything don't work. Well, that causes a problem doing a neuroassessment. So that's why I talk about you have to pay attention to your neuroassessment based on what medications we're giving that patient. Other things that can go wrong with this is we can have cardiac arrhythmias because we get them too cold. They can have coagulopathies, so they clot because they have their blood's cool. They can have pulmonary infection, electrolyte imbalances, and then hypothermia-induced diuresis. So these are all kinds of things that can happen because we cool them. So we are monitoring this patient very, very closely. And we get them cool fast Like, these patients are fun when they come in because you're putting ice down, ice water down their NG to get them cold. You're putting ice in their groin and in their armpits to get them cold. You're putting ice on the neck and around their head to try and get them cold. So we get them cold very quickly, but we warm them up very slowly so that it gives the body time to adjust. So it takes 24 to 48 hours to get somebody fully warmed back up. But therapeutic hypothermia is only used for the first 72 hours. After that, it's not really going to help our patients very much. All right, so after that 72 hours and after we've warmed them back up, we are going to want to maintain normothermia. Because they've had that pressure on the brain, their body may not know how to regulate that temperature and may have a struggle with it. Things that we can use is we can use antipyretics and physical methods, either cooling blankets or warming blankets, depending what we need, bear huggers or something like that, depending on what their temperature is. We want to prevent shivering. And again, remember that shivering uses a ton of calories, and that brain needs those calories and their body needs those calories to heal. So those are things that we might use to try and prevent the shivering. Okay, so we've got our higher temperatures on our cooling blankets, so we can use warm or cool depending on where they are, and we can sedate and paralyze if shivering becomes a problem. Usually not too much of a problem though. Once we've warmed them back up, we don't have too much shivering, more that they spike temps or they cool down, stuff like that, just because their body, their brain doesn't know quite how to regulate that temperature anymore. So it kind of falls on us to figure it out. We have this patient with a traumatic brain injury and we have done all this stuff. We've cooled them, we've done all this stuff, and our ICP is still over 20 and through the roof, and we're not getting the responses we want. Something else we can do is what we call a decompressive craniectomy, okay, or craniotomy is sometimes what it's called too. You will take out part of the skull, and kind of cool, they put the skull in the abdomen. You would think, oh, we keep it sterile or whatever. Really what it is to keep it with the patient. So many patients with traumatic brain injuries have their surgery or whatever in the ICU of whatever town they're in, but then they rehab somewhere else. And so you're going to lose that piece of skull as you go. So they literally put it in the abdomen. They just sew it, they put it in, sew it closed, whatever, so that it stays with the patient. So that they can have it put back in wherever they are. That seems to be helping them a lot more keep track of them. Like I said, this is used when everything else has failed. It's indicated if there's continuous deterioration or signs of herniation. And then if we need to maintain adequate cerebral perfusion and oxygenation, because none of our other things have worked. It's a struggle. We don't like to do them, but we can. Things we have to remember if we have patients that have this is that we have to keep their head safe, because it's like they don't have that skull on that side anymore. So we have to keep that head safe. They'll have to have a helmet when they're up out of bed, when talking more like rehab and that kind of stuff. And you're not going to have you won't have ICP readings anymore, because you've taken off the skull that keeps that pressure in there. So their head might bulge out a little bit as the swelling is there, and then it'll start to slowly kind of cave in a little bit as the swelling goes down. Anytime our brain gets irritated or has something going on with it, we are at higher risk for seizures. And all a seizure is an electrical current in our brain that goes haywire. And we don't want it to go haywire. We want it to have our nice normal functioning. But just like AFib and a cardiac cell deciding that it wants to stimulate the heart, causing that irregular rhythm, that's what a seizure is. But it's in the brain, so then it controls so much more of our body than just that cardiac muscle. So seizures are a huge issue that we run into with traumatic brain injuries, and these patients are typically going to be on anti-seizure medications for probably the foreseeable future, if not the rest of their life, trying to keep the seizures at bay because of the injury and that the electrical current just doesn't have its normal pathway anymore. Other risk factors for seizures is that the GCS is less than 10, cortical contusion, they have a decompressed skull fracture, the subdural, epidural, intracranial hematomas. Anytime we have injury to our brain, we are at risk for seizures. So you can have patients with tumors, you can have patients with anoxic injuries to their brains. Any of that kind of stuff is going to increase the risk for seizures. And the things that we need to worry about are safety things. Okay, as nurses, we need to make sure our bed rails are padded, okay, so that they're safe. We need to make sure that medications are given appropriately so that if we need to give them some Ativan or something like that to make sure that they don't have seizures. And then if they have a seizure, we need to document and understand the time that they're having it, how long did it last, what happened during it and before it, because did something trigger it? Okay, so those are some really important things. And then how were they breathing during it? Did they have apneic periods? Do we have to worry about those kinds of things? The biggest thing though is the time. We need to know the length, because if we start getting seizures that last longer than 3 minutes, we start having problems with oxygenation, and that becomes a very big issue as we worry about these traumatic brain injury patients as they have a longer life, and we don't want them to have seizures and then have problems because of the traumatic brain injury and then the seizures. We don't want them to have continued problems. A recap of avoiding that increased intracranial pressure, because anything over 20 is bad and we want to make sure. Some simple things we can do: maintain head of bed at 30 degrees. Sometimes these patients, we literally will use what we call a tilt table, and it's a table that we strap them down on and we can stand them up. And when we stand them up, that naturally decreases their ICP because they are at that full 90-degree standing up position. The other things we can do, we can maintain that alignment, keeping them just perfectly, perfectly straight, because if we can keep that neck and that whole body aligned, again, it will help decrease those ICPs. Avoid clustering care activities. So normally with our patients, we'd want to try and go in there and do all our activities together, but that might be too much stimulus for a patient that has a traumatic brain injury where we're trying to keep that ICP down. So we might really need to make sure that our activities are simple, small, and they have rest periods between them. Avoid situations that cause a Valsalva effect. We don't want them to bear down. So these are people that we're going to want to make sure we give really good poop meds to, because we do not want them to have constipation. And then we want to minimize that external stimulation. So we're not going to be playing, this is not a room where we're going to have music necessarily. We're not going to have the TV on, and there's no family drama allowed in the room. And if you've ever worked in a hospital, and especially in an ICU, there is always family drama. So we're going to really make sure that we do not allow family drama in that room. And when we go in there, the lights are going to be low, so you're going to have dim lighting, right? Your monitors might be quiet in the room but louder outside the room so that you can hear them, those kinds of things, because you don't want that external stimuli. And then please, 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 don't let them pet your patient. Okay, they can hold their hand, but they don't need to be caressing and rubbing and all that kind of stuff, because that causes increased intracranial pressure, because every time you pet, you're stimulating all those nerves, and every time you stimulate all those nerves, that's all going to the brain and increasing the brain's activity, therefore increasing the stimulus and the ICP. I talked a lot about shivering and how it uses up a lot of calories. Well, TBI patients have increased metabolic needs because they have a huge injury to the brain, let alone if they have injury to anywhere else in their body. They have an increased metabolic rate, so we really need to make sure that we're feeding these patients, okay? We want to begin feedings within 72 hours. A lot of times we'll begin it sooner than that. Depending on what's going on with that patient. We want to maintain blood glucoses between 80 and 120 because we don't want to give too high of sugars to that brain. If we give too high of sugars to that brain, again, all those big glucose cells are pushing through all those really swollen, irritated vessels already in the brain and causing more damage. So we really keep a very tight control on their blood sugars. And we've got to get them eating and get that food in there so that, one, their gut remembers what it's there to do, and to give them that nutrition so that they can heal better from their injury. Nursing diagnosis help us understand what's going on with our patient. For patients experiencing an intracranial dysfunction, the ineffective tissue perfusion is probably your biggest priority. We want to make sure that that perfusion is good. Risk of aspiration and risk for injury related to seizure disorder are all things that we might use for rehab, depending on what's going on with them. Patient with cerebral or cerebrovascular disorder, you've got the decreased intracranial adaptive capacity, but more that ineffective tissue perfusion is, again, we've got to keep that brain perfusing. Then we get into a lot of the rehab stuff with the self-care deficits, risk for impaired swallowing, risk for aspiration, and risk for injury related to seizure disorder. So you can see that these are very similar types of nursing diagnoses that you might need to know for that your charting and your care plans and all that kind of stuff. We've been talking about a lot about traumatic brain injuries, and now we're going to switch over to spinal cord injuries because, I mean, they can happen together, but spinal cord injuries have some of their own very specific interventions and cares that go with them. Spinal cord injuries have a lot of different modes that they can happen. Again, think about physics. It's about the force and the impact that happens. So here we've got that forward momentum. So not only could this person have a spinal cord injury in here to the damage to the spinal cord, they also could have that head injury from the brain going forward and then the brain going backwards. So this person could have a lot going on. You have damage to the spinal cord, so you have an anterior dislocation, and then you have the cord compression and the ruptured anterior longitudinal ligament. So that's that kind of whiplash, but obviously a very advanced one. The other type of injury is compression. So when people fall, they compress and then they break one vertebrae or a portion of the vertebrae. And then that can cause a lot of problem. With the neck injury here, again, a ton of force, sad. We've seen several of these. And then again, that vertebrae just kind of smushes between the force of all the other vertebrae. So these are patients that are going to have lifelong change due to an injury. So there's different modes to injuries, but then there's different placements. And when it comes to spinal cord injuries, placement means everything, because the lower down on your spine, the more movement and independence you will have. So a C4 is considered a quadriplegic, which means they do not have the ability to move the arms and legs. Now, spinal cord injuries can be complete or partial, anterior or posterior. So it really, really depends on the swelling and the mode of injury and just what went wrong and if we fixed it. If we have a C2 injury, you're gonna be what we call a quad, because that's gonna be the patient that is gonna be on a ventilator for the rest of their life. And I mean, they're just kind of their head and brain are still functioning, but they really don't have much else. As you go down the spine, when you get to C6, You're going to have some shoulder movement, which is nice because then a lot of times you have some gross arm movement as well, and they can do some big things with their arm, and rehab can work with them. As you continue down the spine, you get to like T6 area, and you start having the mid chest. And what's nice about that is then you're not necessarily on a ventilator, because if you still have nerve function to your diaphragm, you don't need to be on a ventilator as much as someone who's got a higher level of injury because they can't control that diaphragm. As we go farther down on our back, we get just our legs being involved, and sometimes we can do braces and stuff like that that will help those patients still be able to walk, maybe with crutches or something like that, or use a wheelchair, but they still have functioning of their arms. So spinal cord is very, very unique in the fact that depending on where the injury is, depends on the level of injury they get. Treatment of spinal cord injuries is going to depend on, again, where you are. If you're in that first A, B, C, D of finding a traumatic injured person, and you've got to get them out of their car or whatever, again, paying attention to safety. The thing is you want to make sure if you're getting them out safely. Sometimes it's better just to leave people in their cars until we get the appropriate neck braces and stuff to get them out. We want to maintain alignment. This becomes huge and important. I have had patients brought to the hospital on a door with duct tape holding them in alignment, and the guys did a great job doing that. They didn't have a bodyboard, there. They used what they had, and they kept him aligned, and they actually did a good job saving a lot of his function because they maintained alignment. We want to transport these patients and get them to a facility that can take care of them. Inside the hospital, the biggest thing with spinal cord injuries is this methylprednisolone or solumedrol. It has to be given in a high dose within 8 hours of injury. If we can do that, we decrease the swelling so significantly that we can sometimes bring back a lot of function. And you have to think, guys, these patients have such long-term care because one poor decision of not wearing your seatbelt in the car with your buddies while you're driving on those dirt roads and you roll the car. I mean, that was a quick decision, but that kid that I took care of that did that, he never walked again. We did give him steroids right away when he got to us, and that saved him from a lot of other dysfunctions, but he still had a pretty significant injury. So if we can get them into the hospital and we can get that steroid given within 8 hours, we can really save a lot of function for them by decreasing the swelling and bringing back a lot of function if possible. Supportive care, we're going to get these guys and get them fixed and give them a lot of support because this is a huge life-changing event. They're going to go through a grieving period where they have to grieve the life they thought they had, or one point in time had, so they have to grieve that life. Surgical repair, we're going to go in and fix the bone and stabilize the spine as much as possible. It might take a couple surgeries depending on how bad it is or how swollen it is. Then we're going to get them to rehab. And rehab is huge and important for these guys because they've got to get to rehab so that they can keep the muscle tone that they have. They can learn how to function with what their disability is and maybe get some of that function back. Spinal cords are just crazy unique and crazy cool, but frustrating as all get out too. Central cord syndrome is an acute cervical cord injury, so you're up in the neck area, but it gives upper dysfunction greater than lower dysfunction. So they're going to have more problems with their arms than they are with their legs. And so it's sort of the opposite that we think, but that's a central cord syndrome where the central part of the cord is damaged or hurt. They're also going to have some bladder dysfunctions and other things like that. Anterior cord is blood flow from the main artery and the spinal cord blocked, causing ischemia to the cord. And that's going to cause all sorts of issues. So there may not be injury to the vertebrae itself. There might be, but what it really is worrying about is more the blood flow. And if you don't get blood flow to things, they die, and everything cascaded off of that dies. So we really have to pay attention to the blood flow to it. And then Brown-Séquard syndrome, which is lateral cord syndrome, is there's a lesion on the cord. So more about like a tumor or some sort of lesion, some sort of specific area of damage. And that is then going to depend where that damage is going to depend on their level of injury. Complications of spinal cord injuries. So we've already talked about spinal or neurogenic shock, which is a type of shock going to cause problems with blood pressure and heart rate because the body is just not communicating anymore because that nervous system is not communicating with the rest of it. DVTs become a problem because, again, they're in bed, they're laying there, and we're not getting up and moving. Orthostatic hypertension, so that blood pressure dropping when we do get them up is an issue for them because that upper and lower of the injury is not communicating with each other. And then autonomic dysreflexia is a huge issue. Don't see it too often in the acute phase, but definitely see it in the long-term phase. And I know we have patients at Madonna that frequently have issues with autonomic dysreflexia. Autonomic dysreflexia is an exaggerated response of the autonomic nervous system to noxious, painful stimuli. With injury at or above the level of T6, and that's excessive stimulation of sensory receptors below the level of injury that can trigger autonomic dysreflexia. Arterioles constrict, causing severe hypertension that may lead to seizures or stroke if not corrected. Signs and symptoms are nasal congestion, facial flushing, profuse sweating, pounding headache, bradycardia, severely elevated blood pressures. So all of these kinds of things you can see are all from that severely elevated They're triggered by various stimuli, including a distended bladder, which is probably the most common cause of autonomic dysreflexia, constipation, renal calculi, ejaculation, uterine contractions, but may also be caused by pressure sores, skin rash, enemas, or even sudden position changes. I've seen autonomic dysreflexia caused by a wrinkle in somebody's sock. So literally their blood pressure was 210 over 120, and we gave her some low pressure to try and bring that blood pressure down, being careful because we don't want to bring it too low because once we fix the stimuli, that blood pressure is going to drop naturally on its own, and if we've given low pressure, then it's going to drop even lower. So this can be such a booger to try and work with because you just don't know what's going to happen. But a lot of times if the Foley bag is kinked, that is a huge reason for autonomic dysreflexia. And what it is that below the injury and above the injury can't speak to each other. So it can't tell the brain, hey, this is wrong. My bladder is distended. Something is wrong. The body can't communicate, so it freaks out and causes all this stuff to happen so that we try and figure out what the heck is going on. To wrap up all this trauma fun, let's talk about preventing secondary injuries caused by physiologic responses. We want to do an effective assessment or survey. That survey is those primary, secondary surveys, okay? Because if we do those effectively, we will know what's going on with our patient so that we know what's going to happen and we can anticipate cares that are needed for successful survival. One of those things is we will be able to quickly know if our patient needs to be intubated. If they need to be intubated, we need to get them intubated quickly. Remember, there's only 3 minutes before we start having problems with oxygenation or lack of oxygenation to the brain. So we don't have a lot of time to decide if we want to get oxygen to that brain or that spinal cord or that injury in general. We need to transport them and get them to where they need to be. This is not a time to think that, oh, we're the awesomest hospital and we can do this. We need to get them where good outcomes are proven and can handle this type of patient. Prompt fluid resuscitation for our shock patients. We want to get that fluid in there because remember, it's all about perfusion and keeping that blood pressure up. And if we don't keep that blood pressure up, it's not going to do a whole lot of good to try and save their lives. We need to make sure we're doing appropriate diagnostic tests, whether that be a CT scan, which is quick. We can do a CT scan in about 3 minutes, which is nice and quick to diagnose any injury to the spinal cord or to the bones, at least around the spine, any bleeding in the brain. And so that's probably our preferred diagnostic test for a trauma patient. However, if we have prolonged things, like we think we've had a diffuse axonal injury, then necessarily we might have to do an MRI or something like that. But until then, let's just start with a CT scan and see where we go from there. We want to do our ICP monitoring. And remember, ICP, we want less than 20 because we know that brain's going to be swollen with a traumatic brain injury. But we want it to be less than 20 so that way we know our patient is doing okay. We want to give prompt medications and treatments. This means if we need to get that patient paralyzed or we need to get that patient some steroids for their spinal cord injury, we want to be doing that very effectively and very quickly. Supportive care. This not only goes for the patient, but also goes for the family as they are watching their loved one in a way that they have never seen. And most families, whether they have medical knowledge or not, are going through such an emotional upheaval that they need to have the supportive care, and our patients need to have supportive care to get them through. And then our last part that we didn't talk about a huge bunch, but we can talk about more in class, is rehab. We get them saved, but we got to get them to rehab so that they can have quality of life. Because what is the point of living if we don't have a good quality of life? Thanks and good job for getting through this lecture. I know it was long, but I think it gives you at least a base of information for starting to understand how traumas are just a little bit different than other care that you've already done. After viewing this video, please bring to class something you knew that was reiterated in this PowerPoint, something you learned from it, and at least one question you have from listening to this lecture. And that's how we'll get our class started. And I'm excited to see you guys and get to work together. Thanks and have a great day.